Hello, my name is Professor Lewis White, and I'm head of the Public Health Wales Mycology Reference Laboratory. And today I'm going to talk to you on biomarkers and antibody tests for the diagnosis of a suspected invasive candidiasis as part of the Global Guidelines on Candidal Diseases. Now, when it comes to invasive candidal disease, we typically have two manifestations, candidemia and deep-seated candidiasis. And this can be quite fluid in presentation, with one developing into the other and vice versa. But what we need to consider in regards to biomarker and antibody tests is how these tests perform in the presence and absence of an organism within the bloodstream, and then the utility of these tests in relation to diagnosis in the absence of candidemia. And I think the one sort of take-home message is really the situation that with any test, we're looking really the optimal approach, and this is strongly recommended by the guidelines, is that combining diagnostic tests and interpreting within clinical parameters might be useful for both diagnosing and excluding disease. And the take-home message really is in regard to biomarkers is that they shouldn't really be used on their own as a sole test. So the most common test, most well-validated test in relation to the diagnosis of both candidemia and invasive candidiasis is serum beta-D-glucan, and that has been moderately recommended for the diagnosis of invasive candidiasis and candidemia within the guidelines. In terms of its performance, we have moderate sensitivity as defined by various meta-analyses and systematic reviews coming in around the 80% mark. And subsequently, we have a high negative predictive value, typically around the 95% mark, maybe a little bit higher. And so there's moderate recommendation to support the use of BDG to discontinue antifungal therapy, taking into account that there will be some false negative results. Conversely, specificity, as defined through meta-analyses and systematic review, is sort of average to moderate at best, varying between sort of 64 to 85%. Subsequently, the positive predictive value is not always ideal. Indeed, in a situation where you have a patient who has a high candida score and a pre-test probability of invasive candidal disease of around 10%, a positive beta-D-glucan using the Fungitel test with the specified threshold of around 80 picograms per mil would give you a post-test probability somewhere around 30%. So still far from convincing. So currently the guidelines will say there's insufficient data to support biomarker-driven antifungal therapy based solely on a positive beta-D-glucan result. We're also in a situation where there are various manufacturers and subsequently various kinetics and various thresholds, and of course then there's variable performance. Most of the validations have been done on the Fungitel beta-D-glucan assay from Associates of Cape Cod, but there's now a wide array of different assays currently available, typically with less validation. For some assays, such as the WACO test, it does appear that sensitivity might be slightly less, but conversely, specificity is improved. However, we continue to modify positivity thresholds to enhance sensitivity, but potentially compromise specificity. The other thing to take into account is that beta-D-glucan is pushed forward or promoted rather, as a pan-fungal test, which is not quite the case. It has limited performance in cryptococcosis, doesn't detect mucorales, and has limited performance in some of the endemic fungi such as blastomyces. However, it does pick up many more things other than Candida. And we have to take into account that many of our patients, many of the cohorts who are at risk of invasive candidal disease will also be at risk for other forms of invasive fungal disease, such as invasive aspergillosis, other yeast infections, pneumocystis, etc. And beta-D-glucan can quite conveniently pick up all of these other fungal infections, but not necessarily differentiate between the different types of fungal infection. We're also in a scenario where there's a lot of non-fungal clinical reasons for false positivity in serum beta-D-glucan. And this is just highlighted here, where we have certain medical products, certain medical interventions that can lead to false positive beta-D-glucan results in the form of surgical gauze, surgical sponge, use of cellulose membranes and filters, etc. However, probably the most profound source of false positivity in terms of beta-glucan is intravenous immunoglobulin, where you can get beta-glucan values much higher than 500 picograms per mil immediately after the administration of IVIG. So you do need to be aware of these false positive sources. There's also clinical conditions that can lead to raised background beta-glucan levels, such as Burns patients typically have higher levels, cystic fibrosis patients typically have higher levels, pediatric and particularly neonatal patients will have higher beta-glucan levels, and indeed hematology patients will. So subsequently we need to be aware of that. But arguably, probably the biggest cohort with higher background levels of beta-glucan will be patients post-abdominal surgery or post-abdominal rupture, and they can, due to gut translocation of beta-glucan, have high background levels of beta-glucan. So again, highlighting the fact that these tests should not be used in isolation. Nevertheless, it has been shown that consecutive positivity, where you've got 2, 3, or 4 or multiple positive samples taken in a consecutive nature, does increase the specificity of beta-glucan and pushes it up into sort of the mid-90 mark in terms of a percentage specificity. We do find that performance can vary between Candida species, in particular Candida auris and Candida parapsilosis can generate lesser sensitivity compared to, say, Candida albicans, so something else that needs to be taken into account. And as I've mentioned many times during this short presentation, beta-glucan should not be used in isolation. Currently in the guidelines, beta-glucan is not recommended in the pediatric population. It is felt that thresholds are not yet accurately defined, and so subsequently we can't have confidence in the performance parameters. So moving on now to beta-glucan on the CSF, and particularly it's recommended to a moderate level to use beta-glucan on CSF to help in the diagnosis of deep-seated candidiasis in this situation. Obviously, we're looking at some CNS disease, and it typically has a high sensitivity and high specificity because you wouldn't expect to find beta-glucan in this sample type. When we look at other sample types, there's limited validations, and subsequently we make no recommendation for the use of beta-glucan on things like acidic fluid or drain fluid, etc. The one thing we can be confident in saying that is that beta-glucan has poor specificity when testing respiratory samples due to the presence of colonizing or commensal organisms within the respiratory tract, such as Candida. And typically the specificity of beta-glucan when testing respiratory tract samples, such as BAL fluid, is less than 50%. So we would not advocate, indeed we would say do not use beta-glucan on respiratory tract specimens. The other antigen test, which has been widely used, is the Mannan antigen test, and we recommend that this is performed to a moderate level in combination with antibody. And so you have Mannan antigen combined with anti-Mannan antibody test. And that is because the antigen test typically lacks sensitivity but does provide a better specificity. Conversely, the anti-Mannan antibody assay has a good sensitivity but typically lacks specificity. And in combination, when you have both tests positive, you have a higher specificity. And if both tests are negative, there's a high likelihood that the patient doesn't have disease. There's only marginal recommendation for the use of these tests in CSF in a combined fashion because of limited evaluation on this specimen type. The other antibody test, the Candida albicans germ tube antibody, is recommended at a marginal level due to variable sensitivity and specificity across the studies. And of course, it does target primarily Candida albicans, and performance outside of disease caused by Candida albicans is indeed variable. So it goes forward to a marginal level of recommendation. And so, as I mentioned at the beginning of this brief talk, it is strongly recommended that all biomarkers for candidemia and invasive candidiasis should be used in conjunction with clinical parameters, other biomarkers including PCR, and other diagnostic tools, including conventional diagnosis. Indeed, at this moment in time, we're still to define an optimal strategy incorporating biomarkers and molecular tests to be used alongside conventional diagnosis. And it's hoped sometime in the next few years we will actually devise an optimal strategy that's also useful for confirming disease, but also satisfactory for excluding disease. I do hope you found this brief presentation useful, but I do urge you, I do encourage you to take a look at the full Global Candida Guidelines, including the appendices where much of the information is basically based that underpins our recommendations and is a very good read. Thank you very much.